Good morning. My general presentation is on the topic sodium glucose co-transporter inhibitors for the prevention of kidney failure in patients with type 2 diabetes, systematic review and meta-analysis. The journal was published on 5th September 2019. My moderator is Dr. ML Bhatt. Introduction. Diabetes has become one of the leading causes of kidney failure. About 2.6 million people are estimated to have received dialysis or transplantation of the kidney due to failure, of which more than half are due to diabetes. Treatment with AC inhibitors and ARBs has proven to prevent the major adverse kidney outcomes, but there is still a residual risk. Sodium glucose cotransporter inhibitors are glucose lowering agents that also lowers the blood pressure, lowers the body weight, and also prevents albuminuria. Its action is by inhibiting the sodium glucose cotransporter, which is present in the proximal converter tube of the kidney, and thereby decreasing the reabsorption of glucose, hence lowering the renal threshold of glucose and increase urinary excretion of glucose. Since glucose is excreted through urine, it also helps in weight reduction. And since sodium reabsorption is also inhibited, it has a diuretic effect, leading to decreasing the blood pressure by 3 to 6 millimeters of mercury. Because there is increased excretion of glucose through the urine, the patient will have a high chance of recurrent UTA. Research objective and methodology. Systemic review and meta-analysis on sglt2 inhibitors and effect on major kidney outcomes in patients with type 2 diabetes is the research objective, and the data are obtained from Medline and MPACE, and the data collections were up to June 14, 2019. The primary outcome was composite of dialysis, transplant, and death due to kidney disease. Random effect models were used to obtain summary regarding the relative risk and confidence interval. Again, random effect meta-regressions were used to explore effect modification by subgroups of baseline EGFR, albuminuria, and use of renin-angiotensin system blockage. Trials with extension period and those including participants with type 1 diabetes or those younger than 18 were excluded from the study. So as I told you, the primary outcome of interest was a composite of chronic dialysis, kidney transplantation, and death due to kidney diseases. Other kidney outcomes assessed were substantial loss of kidney function, end-stage kidney disease, or death due to cardiovascular or kidney diseases, long-term EGFR slope, and acute kidney injury. Substantial loss of kidney function was preferably defined as a sustained doubling of the creatinine, representing a roughly 57% decline in the kidney function. Where sustained doubling of the creatinine was not reported, sustained 40% decline in the EGFR or non-sustained doubling of the serum creatinine was considered. Now, coming to the studies, 4 studies were considered. The EMPA-REG study, which dealt with empagliflozin, Canvas program, which took canagliflozin, Declare Time 58, which used dapagliflozin, and Credase again used canagliflozin. The mean age of the participants were 63 in all the 4 studies, and about 60 to 70% of the participants were men. The study also took into consideration the patients with different EGFR, like greater than 90, 60 to 90, 45 to 90, less than 45. But most of them coming with the EGFR greater than 90 or 60 to 90. It also used urine albumin and creatinine ratio. Coming to the results, all 4 studies compared the SGLT2 inhibitors with matching placebo. Meta-analysis included data from about 38,723 randomly assigned participants from 6 continents. The mean age across the studies, as I told you, was from 63 to 63.9 years. From the study, we came to the conclusion that SGLT2 inhibitors treatment reduced the risk of dialysis, transplantation, or death due to kidney disease by 33% when compared to the placebo. Also, It reduced the risk of end-stage renal disease by 35%. It reduced the risk of substantial loss of kidney function, end-stage kidney disease, and death due to kidney disease by 42%. And treatment with SGLT2 inhibitors lowered the risk of acute kidney injury by 21%, 25%. Magnitude of benefit might be attenuated, like if the benefit is more in patients with high EGFR and it declines as the EGFR declines. However, significant evidence of benefits was apparent for all EGFR groups, including for participants with baseline EGFR lower than 45 ml per minute per 1.3 meter square, in whom a 30% relative risk reduction was identified. Clear and consistent benefits were also apparent when the participants were subdivided into those with EGFR below 60 and EGFR 60 and above. Absolute benefit in terms of EGFR decline was seen in the fourth study, Credence, which took canagliflozin into consideration. That is a 2.74 ml per year. Coming into the study, all four studies had an odds ratio less than 1. This vertical line denotes the odds ratio of 1. So all the cases had a value which is less than 1 with significance, p-value of 0.0019, which shows the study is significant. This figure shows the effect of SGL2 inhibitors in end-stage kidney disease, substantial loss of kidney function, and death due to kidney disease, and cardiovascular and kidney diseases. In all the studies, the odds ratio has come below 1. It shows that it does a significant role in reducing the risk of kidney injuries. Figure 3 shows the effect of SGL2 inhibitors on acute kidney injury. Figure 4 shows the effect of SGL2 inhibitors in major kidney outcomes individually. Figure 5 shows the effect of SGL2 inhibitors on substantial loss of kidney function, end-stage kidney disease, death due to kidney, and stratified by baseline EGFR. Coming to the discussion part, from the study, the systemic review of meta-analysis shows that SGL2 inhibitors can reduce the risk of dialysis, transplantation, or death due to kidney disease, with compelling evidence of benefits on a broad range and other clinically important kidney outcomes. The renoprotective effect was achieved across all levels of baseline kidney function, down to an EGFR of 30 ml, with a clear benefit seen even from subgroups with baseline EGFR between 30 to 45%. The glycemic effect of SGL2 inhibitors was directly proportional to the glomerular filtration rate. Furthermore, the renoprotection with SGL2 inhibitors seems consistent irrespective of the baseline use of RAS blockage. Drawback of the study is that the effect of SGL2 inhibitors on kidney outcomes in patients with EGFR lower than 30 ml per minute is not dealt with in the current study.